Hi, I'm Adriana reporting from FITS on the Go at the American College of Cardiology Scientific Sessions 2022 here in Washington, D.C. And I have the distinct pleasure of interviewing the esteemed Dr. P.J. Devereaux from Hamilton in Ontario, Canada, who is the principal investigator of the POISE-3 trial, as well as the director of the Division of Perioperative Care at the McMaster University and current president of the Society of Perioperative Research and Care. Dr. Devereaux, thank you so much for joining us today.
Thank you so much, Adriana, for having me. I'm not sure I'm esteemed, but I'm happy to be here.
There's been a lot of interesting trials being presented at this year's ACC, and one that we're particularly interested in learning more about is the POISE-3 trial. Dr. Devereaux, could you give us a background of what the POISE-3 trial is, its design, and its main findings?
Sure. Well, thanks so much for the opportunity. So when patients undergo non-cardiac surgery, they are at substantial risk of bleeding. And bleeding can lead to lots of negative consequences, and for us as cardiologists, it often will stop or delay the restarting of our antiplatelet and anticoagulant interventions. So in the cardiac surgery setting, there's been large randomized control trials showing that tranexamic acid reduces the risk of bleeding, and it does it safely. Because non-cardiac surgery is so much more common than cardiac surgery, well over 95% of the surgeries, we decided to study this to see whether or not we could safely prevent bleeding in this setting. Now, tranexamic acid is an antifibrinolytic drug, and because it's an antifibrinolytic drug, there is always the concern, could it cause thrombotic events? So we equally wanted to know, would it prevent bleeding, but at the same time, would it be safe and not cause vascular thrombotic events? So we randomized 9,535 patients in 114 centers in 22 countries to receive either tranexamic acid or placebo, 1 gram IV at the start and end of surgery. 99.9% of the participants completed a 30-day follow-up. We had a primary efficacy outcome, which was a composite of life-threatening, major, and critical organ bleeding. Tranexamic acid reduced the risk of this. So in 9.1% of the patients in the tranexamic acid group, they had a major bleeding event, whereas it was 11.7% in the placebo group. This is consistent with about a 25% relative risk reduction, a result that was highly statistically significant. In contrast, when we look at the major vascular events, we had 649 events in the tranexamic acid group, and we had 639 events in the placebo group. So in just under 1,300 events, it was only an absolute difference of 10 events between the two groups. The hazard ratio was 1.025 or 24, and this was not statistically significantly different in a conventional sense, but the upper 97.1% confidence interval, which represents our non-inferiority boundary, we had a priori set as 1.125, and it was just above that. So we cannot claim non-inferiority. However, it's important to put in context that what our results show is that there's a 96% probability that it is below the hazard ratio of 1.125, and there is no real absolute difference between the two results. So this certainly demonstrates that, patients and surgeons and anesthetists can expect that you can get about a 2.7% absolute reduction in major bleeding by giving tranexamic acid, and you have to weigh that against a very low probability of even a small increase of 0.3% in a potential vascular event.
Dr. Devereaux, let me ask you, how do you anticipate trial findings impacting real-world patient care in the coming years?
So, sure way to not have something happen is to tell people exactly what to do. I mean, obviously, what I encourage people to do is look at the evidence, and you can ask yourself a simple question. Given the evidence of unequivocal benefit and very, reassuring safety data, if your loved one was about to have a major surgery, would you want them to have tranexamic acid or not? And I think the answer is relatively clear. So we're hopeful that, in fact, we will see a substantial uptake of this in the non-cardiac surgery setting. Now, this has important relevance because at a global level, there's 30 million units of transfusion that the world is short every year in terms of being able to provide to people who need blood products. So we have a global shortage, and surgery makes up 40% of all transfusions. And because there's 300 million adults who are having major surgery on an annual basis, the POISE results suggest that if tranexamic acid became standard care, we could prevent about 8 million major bleeds that result in transfusions, which would obviously go a long way to helping to address the global problem that we have with the shortage, and just highlights the potential for very important public and clinical endpoints that we could actually impact with this.
And Dr. Devereaux, last question. What does the future hold for the POISE trials? We've seen POISE-1, POISE-2, and this year, 2022, we are learning about the POISE-3 trial. What is the future plans of the POISE trials?
Thanks. Well, hopefully there'll be lots more. Some exciting areas that we're working on and spending a lot of time now on is using remote automated non-invasive technologies that can allow us to measure after surgery when patients go to surgical floors, but also transition home, continuously non-invasive your blood pressure, your heart rate, your heart rhythm, 5-lead ECG, temperature, respiratory rate, oxygen saturation. And what we know is that a lot of patients who go back to surgical floors, they're post-anesthetic and they're on narcotics and they don't have normal alert mechanisms. And we've identified that a lot of people start getting into hemodynamic compromise, start getting hypoxic, and because the reality is of the nursing to patient ratio, most people are getting their vitals, if they're lucky, checked every 6 hours, commonly it's every 8 hours. So we're magically hoping that the nurse happens to arrive 5 minutes after things start going south and identifies that and is responded to. We believe by using smart technology in the future, nurses will never measure vitals. Smart technology will continuously measure this for us. And so what we're doing research with now, and what we hope POISE-4 and other studies will be, is that we'll randomize people to this technology after surgery versus normal monitoring to see whether or not we can identify the events early, intervene when it's just a minor problem, to prevent major problems and improve outcomes.
Well, it's been a great discussion and very exciting times for the POISE trials. Dr. Devereaux, thank you so much for your time, and thank you to our listeners who are watching this interview. For more interviews and other late-breaking trials, please visit our YouTube channel at youtube.com/fitsonthego.